what gets postprandial hyperglycemia in type 2 diabetes? Voglibose is effective choice as a monotherapy. Voglibose with metformin combination for patients for the glycemic control. Voglibose and repaglynide combination to control the postprandial hyperglycemia. Voglibose and triple drug combinations is effective in the Indian type 2 diabetic patients. And finally, few take-home message points. See, as you all know, that diabetes is an Indian epidemic. The results from the recent ICMR India study estimate Indian diabetes based on this criteria is about 10.1 crores. That's the type 2 diabetes living in India. And nearly the equal number, more than that, nearly the 13 crores are the pre-diabetics. And if you combine the diabetics and the pre-diabetics to the tune of about 24.5 crores in Indian population. The prevalence ranges from the different states. The lowest in Uttar Pradesh, 4.8%, and highest in Goa, nearly 26.4%, and even 26% in Hyderabad also. The high prevalence translates to a large population at risk of cardiovascular diseases. So the diabetes is almost equivalent as the myocardial infarction. So the more the diabetes, more the hyperglycemia, more the risk of the cardiovascular diseases. And in fact, the most common cause of the death in diabetes is myocardial infarction. So the prevalence of diabetes in India is considerably higher than the previously estimated, and the epidemic will continue to accelerate. And now the diabetes is occurring in India at a younger age group also, at least 2 to 3 decades earlier to the Western population. Even type 2 diabetes is common in the children nowadays because of the childhood obesity and physical inactivity in the schools. See the differences in the glucose regulation in type 2 diabetes and non-type 2 diabetic patients. And if you see the non-diabetic and the diabetics in the fed state, in a non-diabetic, so because of the GLP-1 receptor stimulation following the oral glucose, so this GLP-1 receptors, GLP-1 agonists, so they act on the level of the beta cells, alpha cells, liver, gastrointestinal system, and also to reduces the satiety. So definitely that keeps the blood sugars at a normal levels, and to improve the insulin sensitivity, and also the sugar will enter into the muscle and the adipose tissues as there is increased insulin sensitivity in a non-diabetic individual in the fed state. What will happen in a diabetic situations when the fellow is in a chronic hyperglycemia? So in chronic hyperglycemia in a fed state, there will be hepatic glucose output. So the blood sugars in the will be very high and leads to the hyperglycemia. Not only that, in the alpha cells keep on secreting the glucagon in the fed state in a diabetic individual. So that glucagon also promotes the liver to release more and more the glucose. So the hepatic glucose production also will be increased in the presence of the glucagon, because glucagon is antagonist to the insulin. So that is how in a fed state there will be the hyperglycemia. See the carbohydrates in Indian diets, the reason for the postprandial hyperglycemia, the Asian Indians are believed to have a lower capacity to clear the glucose load even during the normoglycemia. A typical Indian meal is largely composed of the carbohydrates, and that too the carbohydrates of the simple carbohydrates, and not the complex carbohydrates or complex carbohydrates. So they take the lot of the polished rice in South India. So there is more of the simple carbohydrates. Consumption of the staple cereals forms the major source of the carbohydrates in the Indian diet. So the more the rice, so the more the postprandial hyperglycemia. This is the START study. About 796 participants were enrolled. Nearly 385 is the type 2 diabetes, and nearly 400 plus are the non-type 2 diabetes. Here the carbohydrates constitutes about 64.1% of the total energy from diet in the type 2 diabetic participants, higher than that recommended in the India. So usually we recommend the carbohydrate for the type 2 diabetes between 50 to 60%, that to the complex carbohydrates. But in this study, so the carbohydrate content is nearly to the 65%. Type 2 diabetic participants consume the high carbohydrate in their diet, which has a direct effect on the postprandial blood glucose and insulin response. See, this is the region-wise macronutrient intake in the type 2 diabetics. The total carbohydrate percentage is 63% in the North India. In the West, it is about 61%. Central India 67%. East India 65%. And South India 64%. And if you see here, so unfortunately, the protein content, the protein intake is much lesser in our Indian diets. So it should be between 15 to 20%, but most of the Indian diets, the protein content is less than the 15%. Postprandial hyperglycemia is a concern in the Indian scenario. If you take a fasting hyperglycemia, the postprandial hyperglycemia, most of the times the fellow is in the postprandial hyperglycemia, whether are in absorptive hyperglycemic phase. So this is directly an independent risk factor for the cardiovascular diseases. So the Indian diets are carbohydrates, especially the rural Indian. The carbohydrates are very, very high to the tune of nearly 80%. Postprandial hyperglycemia contributes to the elevated A1C levels. It has closer association with the A1C than the fasting blood sugars. As per the TIDE study, nearly 63% patients had postprandial hyperglycemia of more than 180, out of which 87.7% had HbA1c more than the 7%. See, unfortunately, in Indian people, the average HbA1c in Indian patients to the tune of nearly 9, more than the 9. And here, this is all because of the postprandial hyperglycemia. So, what are the new frontiers for the diabetes management in postprandial hyperglycemia? So, this is the ADA 2024 guidelines. The peak prandial blood glucose should be less than the 180. So, you have to keep the A1C less than the 7%. See, this A1C between 6.5 to 8 depends on the individuals. Suppose if the patient is elderly, having nephropathy, or with high comorbidities, or living alone, so definitely we will keep the A1C at about 7.5 or the 8. On the other hand, if the fellow is a young fellow without any comorbidities, so we have to keep the HbA1c as close to the normal as possible, to less than 6.5%, even at the 6% also, but not at the cost of the hypoglycemia. Preprandial capillary blood glucose between 80 to 130 and postprandial is less than the 180. So in fact, no, I always tell to my patients that even the postprandial around 140 is ideal, because the normal blood sugar means the fasting less than 100, postprandial less than 140. Diabetic means fasting more than 126, postprandial more than 200. See, even at the postprandial 180, it is impaired glucose tolerance. So better to keep the postprandial even at 140. So the peak prandial blood glucose should be less than the 180. Targeted A1C goals are not met despite reaching the preprandial glucose levels. Postprandial glucose measurement should be made 1 to 2 hours after the beginning of the meal. Generally peak levels in the people with the diabetes. See, as I told you earlier, that PPG contributes to a substantial amount of the HbA1c up to the 9%. If you see the HbA1c less than the 7 and the more than the 9%, it is the postprandial glucose or the basal glucose. When it is less than the 7, it is more of the postprandial glucose responsible rather than the basal glucose. When it is more than the 9%, it is the basal glucose that is more responsible for the contribution of the HbA1c. Postprandial hyperglycemia correlates with an increase in the cardiovascular events. So the more the hyperglycemia, so there will be the more the oxidative stress, more the endothelial dysfunction, more the vascular inflammation. So these all will lead to the endothelial dysfunction, and it reduces the nitric oxide levels in the vessels and releases the more and more vasoconstrictors. So it finally leads to the endothelial dysfunction and more cardiovascular events. So to avoid the cardiovascular events, So one should keep the blood sugars as close to the normal as possible. Otherwise, so there will be more and more oxidative stress and inflammation because of the severe hyperglycemia. See, postprandial hyperglycemia lead to the chronic complications. These are all the various studies. Postprandial hyperglycemia will lead to the retinopathy, coronary artery disease, sudden cardiac deaths, neuropathy, mortality from CAD, major CAD, increased stroke risk, increased peripheral vascular risk. So whether it is the whether it is the microvascular complications or the macrovascular complications, so they are more in the presence of postprandial hyperglycemia. So these are the different surveys: National Health and Nutrition Examination Survey, Heart Study, Italian General Practitioner Study, Whitehall Study, etc. So all these findings, when the postprandial hyperglycemia more than 194, there will be threefold increase in the retinopathy despite the normal fasting blood sugars. In the same way, the coronary artery disease is twice high in the postprandial blood sugars between 157 to 189. Sudden death doubled with the postprandial glucose more than the 151. So that is why I am saying that even 150 or 151 is responsible for the more cardiac deaths. So definitely we have to keep the blood sugars as close to the normal as possible. See, postprandial hyperinsulinemia is a predictor of the CAD. CAD events correlate with the half-an-hour postprandial hyperinsulinemia. So this is an independent risk factor for almost all the complications is the postprandial hyperglycemia. The same thing here in the diabetic interventional study, Bedford study, Decode study, etc. They say that postprandial blood sugars and not the fasting was independent risk factor for MI and the cardiac death. Protection from the CAD lost when elevated postprandial blood sugars occurred. Increased postprandial blood sugar levels and intellectual functions are also will be deteriorated, impaired cognitive function with the hyperglycemia. Increased risk of CVD mortality is higher. Reduction in the post meal but not the fasting associated with the reduction in the coronary intima media thickness, leading to the more and more CVAs. So the Decode study, that is Diabetes Epidemiology Collaborative Analysis of the Diagnostic Criteria in Europe, that also says that the same thing, 2 hours blood glucose levels following the 75 grams OGTT, better predictor of all cause and cardiovascular deaths than the fasting blood sugars. What about the Voglibose? See, Voglibose inhibits the glucose absorption. Alpha glucose inhibitors, they are the class of the oral antidiabetic drugs that primarily act on the postprandial hyperglycemia because they reduces the absorption of the glucose from the gut. They regulate the availability of the glucose for the intestinal absorption by modification of the carbohydrate digestion. It is an alpha glucosidase inhibitor which decreases the carbohydrate absorption and decreases the postprandial hyperglycemia. It has a better tolerability than the acarbose. Acarbose causes a lot of the gastrointestinal side effects, so it is not palatable. So that Voglibose is more better acceptable drug when compared to the acarbose. It inhibits the glucose absorption. You see the picture here without the alpha glucosidase inhibitor and with the Voglibose. So without the AGS, there will be the upper small intestinal, the glucose is absorbed, and the lower small intestine, so that's the large intestine. Whereas with the Voglibose, there will be the reduced disaccharide digestion from the small intestines, and also the higher disaccharide content in the lower smaller intestine. So the less glucose is entering into the blood. So there will be the reduction in the postprandial hyperglycemia. So that is the effect of the Voglibose, that reduces the digestion of the disaccharides, leads to the reduced postprandial hyperglycemia. The dose initially 0.2 milligrams DID before it is the meal, so before the breakfast, before the lunch, and before the dinner. So otherwise you can use as the BD also before the lunch and before the dinner. The maintenance may be increased up to the 0.3 milligrams. You can start with the 0.2. If the patient is acceptable and without any side effects, then you can move on to the 0.3 milligrams BD to TID. The maximum dose is 0.6 milligrams 3 times a day, but usually 90% of the cases we use only 0.3 milligrams TID. A slow upward titration of the dose, preferably with each meal, for an adequate length of the time is required. start low and go slow approach helps them minimize the gastrointestinal side effects seen with the AGS, because the side effects mostly it acts on the gut, so it has the side effects pertaining to the gastrointestinal system, like some nausea, vomiting, abdominal cramps, increase in bowel activities, etc. What about the Voglibose versus the acarbose and the miglitol? In the absorption, Voglibose is poorly absorbed, acarbose is also poorly absorbed, whereas the miglitol is completely absorbed. Distribution, lumen of the GI tract, whereas the extracellular fluid distribution is the acarbose and miglitol. Metabolism, intestinal enzymes and the microbial flora, whereas for the acarbose, it is the gastrointestinal tract principally by the intestinal bacteria, also by the digestive enzymes. Excretion 98% fecal, 5% is the renal, whereas the acarbose 51% is the fecal and 34% the renal. Hepatic impairment used with the caution in Voglibose, used with the caution in the acarbose also. Renal impairment used with the caution, no dose adjustment is required because the locally active in the intestinal tract. In the same way, the acarbose is also not recommended in the patient with the creatinine clearance less than the 25. In elderly, should be initiated the lower dosages and careful administration under the observation. In acarbose also can be safely used in the elderly population. So this is the RSSD guidelines. Recommendation for the Voglibose in the triple combination. See the wheel, this is the RSDDI wheel. B stands for BMI, C for the CKD, D is the duration of the diabetes, and H is the hypoglycemia. So here you can use the Voglibose to reduce the hypoglycemia concern. In the chronic diabetics, so definitely there is a role for the Voglibose. In the CKD population, you can safely use the Voglibose. And the BMI, so the more the BMI that shows definitely the carbohydrate intake or to reduce the carbohydrate absorption, so you can use this Voglibose. So the obesity, CKD, chronic duration of the diabetes, and to avoid the hypoglycemia, so definitely there is a role of the Voglibose in this RSDDA wheel. It is effective choice as a monotherapy also. So both the Voglibose and the acarbose are efficacious gastrointestinal adverse events seen more with the acarbose. So Voglibose, miglitol and acarbose are efficacious. Voglibose better than the acarbose and the miglitol in terms of the safety. So nowadays, 99.9% we are using the Voglibose from the AGI class of the drugs that have. So now compared to the sitagliptin showed a better control on the glucose elevation after the meal, more reduces the postprandial. Voglibose has less adverse events when compared to the acarbose. Effective and the PPC control cannot be achieved with the diet alone. So Voglibose monotherapy is effective on the postprandial glucose levels in type 2 diabetic patients whose postprandial glucose cannot be achieved with the diet control only. Now what about the combination with the metformin? See, you all know that metformin is the very important drug to be used in diabetics of Indian origin, because all the Indians will have the more and more insulin resistance, and the metformin is the one of the important drugs to be used to reduce the insulin resistance in all the diabetic individuals, to improve the insulin sensitivity. So the metformin can be used started from the 500 milligrams OD, and slowly you can update the dose to the maximum dose of maybe 2 grams to 3 grams depending on the body weight. And the Voglibose, you can use the 0.2 milligrams with the major meals, and slowly you can update it to the dose of 0.3 milligrams TAD. So here about 187 eligible patients, age between 20 to 70 years, A1C levels of 7 to 11%, randomized into either Voglibose metformin or metformin alone for 24 weeks. A change in the HbA1c levels from the baseline was measured at the week 24. So let us see the targets. See the mean difference in the glycogen hemoglobin with the Vogomet and the metformin. So with the metformin alone and metformin as the Voglibose. So the reduction in the HbA1c is more with this combined drug rather than the metformin alone. And the mean difference in the HbA1c from the baseline over the time, reduction 1.62 plus or minus 0.7 in the combined drug combination of voglibose and metformin group when compared to the metformin alone. Voglibose and the metformin combined group treated patients achieved the target HbA1c levels in a better way. See, the same way the 2 hours postprandial blood glucose reduction is also more with this combination of voglibose and the metformin. So changes in the 2-hour postprandial blood glucose levels are larger in the combined voglibose and the metformin group compared with the metformin alone. So in the combined group there is a reduction of the postprandial to the tune of 52 milligrams, whereas the metformin alone is about 45. However, between the group differences is not statistically significant here. And what about the voglibose with the repaglinide combination? So the fixed dose combination of the voglibose and repaglinide in the management of the postprandial hyperglycemia in the Indian subjects. It's a randomized open label, non-comparative, single-centric. With a total of 15 type 2 diabetic patients, mean age 69 plus or minus 3. Each patient was administered a fixed dose combination of the voglibose and the repaglinide. Here the repaglinide is available in the 2 strands, 0.5 and 1 milligrams, just before each meal for about 30 days. So at day 30, postprandial glycemic levels were significantly lower when compared to the baseline. So this combination of the voglibose and the repaglinide in controlling the postprandial hyperglycemia, so reduction of the blood sugars to the tune of about 61 milligrams. What are the voglibose in the triple drug combinations? See, the voglibose, metformin and the glimepiride combination. So by using this, you can attack the omnious uptake. So the voglibose will act on the intestines, the glimepiride will act on the beta cells to release more and more insulin, and the metformin will act on the liver, about 80%, and 20% it also acts on the muscle and adipose tissue to improve the insulin sensitivity, and in the liver to reduce the insulin resistance at the liver, to tackle the to reduce the hepatic glucose output. So that's how this combination is very, very important. Need to improve the glycemic control by using the appropriate fixed dose combinations. So this is the RSCT guidelines recommendations for the voglibose and the triple combination. The triple or the quadruple therapy is a patient-centric approach. If glucose targets are not achieved with the 2 agents, start the third oral agent like AGA, DB4 inhibitors or SGLT2 inhibitors, or thiazolidinediones, or oral GLP-1 receptor agonists like oral semaglutide. So these are the different drugs. So usually, if most of the people know, they use the glimepiride plus the metformin combination, but still the blood sugars are very high, and definitely you need the third agent to be added, and these are all the drugs. So this addition of the third agent with your glimepiride and the metformin varies from the person to the person. For postprandial hyperglycemia, AGA, glanides or SGLT inhibitors may be considerable if not contraindicated. See, the voglibose in the dose of 0.2 and 0.3 as an add-on to metformin and sulfonylureas is an effective choice in obese type 2 diabetic patients. In obese patients, voglibose dose 0.2 to 0.3 milligrams as add-on to the metformin and sulfonylureas optimize the glycemic control. Voglibose is well tolerable in patients with overweight or the obese type 2 diabetic patients. See here, instead of the glimepiride to be added to be used in the obese population, so you can use the metformin plus SGLT2 inhibitors or the GLP-1 receptor agonists, and then you can add the voglibose. That would be the good choice in the obese individuals to use the 3 drugs rather than the glimepiride. Voglibose in doses of 0.2 and 0.3 as an add-on to metformin and sulfonylureas is an effective choice in obese type 2 diabetic patients. In a triple drug combination improves the glycemic parameters. So there will be a significant reduction in the HbA1c, MACE, PPG, fasting blood sugar, and reduce the time above the range. So these are all very important to have the glycemic See, earlier no, we tried to reduce the fasting postponed HbA1c, but now you have to see the glycemic variability and also the quality of the life. So all these things will be improved if you use the triple drug combination. So it reduces the triple drug combination, reduces the glycemic excursions. So the post breakfast, post lunch, post dinner. So there will be the more and more euglycemia, and no serious adverse effects were noted in this combination. So this combination 0.3 Voglibose, 0.5 500 milligrams metformin, and 1 mg glimepiride is efficacious over the metformin plus glimepiride combination alone. So the add-on therapy using the Voglibose in the dual therapy showed a very significant benefit in controlling the glucose triad levels, that is your fasting, postprandial and HbA1c when compared to the dual therapy. So in summarizing the few take-home portions, Asian Indians have a cereal-based diet which is high in the total carbohydrates. In diabetic population, there is a clear link between the carbohydrate intake and the postprandial glucose levels. Alpha glucose inhibitors such as the Voglibose can help to reduce the BP. Voglibose in combination with metformin showed to be more efficacious as compared to the metformin alone. Voglibose in combination with the repaglinate, they reduce the postprandial blood sugars very effectively. Fixed drug combinations help in reducing the pill burden. It improves the glycemic control and medication adherence at a lower cost. Combination of the metformin, glimepiride and Voglibose found to provide a good glycemic control with good safety and tolerability. Selection of the right patient, right drug, right dosage and right duration are the best keys for improving the clinical outcomes. So thank you very much for your patient hearing. I will be very happy if you have any queries.